In this lecture we will discuss about the pathological process of inflammation, where I will try to simplify some topics, but overall it shouldn't be too difficult because it's very basic. It's a very basic pathology. So inflammation is basically a response of vascular connective tissue towards injury. Any type of vascular connective tissue injury will result in inflammation. And almost every tissue in the body is well vascularized. Therefore, almost any tissue in the body that is injured will produce inflammation. And this injury could be physical, chemical, microbial, immune related, or due to radiation, etc. So this process of inflammation, it has two main benefits. The first one is to provide a defense for the cause of injury, and the second one is to remove dead cells from the site of injury. So it removes debris in order to make room for repair. And inflammation can be divided into two types. The first one is acute inflammation, which is rapid short-lived response to injury, and it basically involves different types of immune cells, mainly neutrophils. And the second one is chronic inflammation, and this is like a inflammatory response which lasts for a long time. So it speaks for itself. Acute is rapid and chronic is lasts for a long time. And you have inflammation according to basic cardinal signs of inflammation. So those involve hot, the tissue becomes hot, and this is due to a dilation of blood vessels once the inflammation occurs. Second one is pain, and I will elaborate on each one later on, but pain is basically due to some mediators of inflammation that are released, like prostaglandin E2, and redness, and this is because, again, increase of blood flow and chemical mediators of inflammation. The tissue becomes also swollen, and there is also loss of function. So those are the basic cardinal signs of inflammation of any type, acute and chronic. So, in the beginning of the inflammatory process, we of course have an injury to a parenchymal cell or a stroma cell, which induces this process of inflammation. And again, the parenchymal cells, they are functional cells of a certain tissue. For example, in the CNS there are neurons, in the liver there are hepatocytes, and in the kidney there are nephrons. And stroma cells, they are cells that support the parenchymal tissue. For example, glial cells, vascular cells, macrophages, and fibroblasts. So any injury to those type of cells will induce the process of inflammation, and this is because those cells they are surrounded by vascular connective tissue, which contains around it a lot of mast cells. Mast cells are cells of the immune system, and they are responsible. Basically, they are the main cells which induce the process of inflammation. So let me make you a quick diagram which will help you to understand. So basically, if we have a mast cell, and due to any type of injury, it will cause irritation. Basically, this mast cell, even before it begins to do something, it has inside it preformed granules which contain the chemical mediator histamine. Okay, inside there is histamine. So any irritation to those cells will cause the granulation of those granules, which will release histamine. And the main purpose of histamine, and I will elaborate about this, is to cause arterial dilation. And this is in order to bring more blood supply to the place where there is the inflammation, where the inflammation occurs. And this is in order to bring more white blood cells to this place. So basically there will be a release of histamine. And also afterwards why this cell is so important? Because the cell membrane, it contains something that is called phospholipase A2. So when the muscle is irritated, there is a certain injury to the cell membrane, and the enzyme phospholipase A2 begins to work. And the idea with this enzyme is that basically phospholipase A2 breaks down to arachidonic acid, and arachidonic acid will go to two different pathways. It will be acted upon, by two different enzyme groups. One is cyclooxygenase, okay, and you can, let's call it COX, cyclooxygenase, and lipoxygenase. See, nice. So the idea with COX is that it will basically be responsible to synthesize the mediators of inflammation, which are prostaglandins, okay, and also leukotrienes. And lipoxygenase will help in synthesizing also certain types of leukotrienes. So the idea is, when we first have irritation of a mast cell, the first mediator that will be released is histamine, because it's preformed, and later on, due to the enzyme phospholipase A2 being active and breaking that on arachidonic acid, and then acted upon by two enzymes, cyclooxygenase and lipoxygenase, other mediators of inflammation will be released, but this will be later on because it takes time to synthesize them. So basically, this release of chemical mediators of inflammation, it can be expressed into events, vascular events and white blood cell events, and this is just to help you understand the process better. Okay, so about the vascular events, before I go deep to the vascular events of inflammation, I want to explain to you some basic concepts. So first of all, arterioles. Arterioles are small blood vessels which are very elastic. They are not the smallest blood vessels, that will be capillaries, and they basically, you can say that they control the amount of blood that is supplied to each tissue, because they control the resistance, the total peripheral resistance to the total peripheral resistance that is given to the blood. So of course, if they dilate, then more blood can come, and there's an increase in hydrostatic pressure. Blood has more room to flow, and if they contract, the perfusion reduces. So let's make a diagram. If this is the aorta, okay, let's say from the aorta an artery comes out, okay, and the artery goes on, and then it starts to become smaller. This is basically the arteriole, okay, and as I said, it's very elastic. It contains a lot of smooth muscle which can expand and contract, controlling the total peripheral resistance. Normally, I should mention that expansion of the arterioles, when they expand, they elevate the diastolic blood pressure because the heart, okay, which is, let's say, 0, has to contract against an elevated pressure. Okay, let's say if they are like this, so the heart has to generate more force to pump the blood forward. But if they dilate, okay, if there's arteriolodilation, the heart has to, it has to work less in order to pump the blood forward. So this is basically their job. They control the TPL. And another basic concept is that after the arterioles we have endothelial cells. We have capillaries. Okay, they are even smaller blood vessel. And after the capillaries we have venules, and then I should make it blue. We have venules and then veins. So let's go back to the capillaries. The capillaries contain endothelial cells, which normally they are tight. Okay, normally they do not have intraendothelial gaps. This is normally. This is in order to prevent small or larger molecules from passing. So for example, normally albumin can just enter to the intraendothelial space into our tissue. So yeah, this is normally they don't contain intraendothelial space. As I said, endothelial cells in normal circulation do not have gaps in between them, therefore normally plasma proteins like albumin can't leak out into interstitial fluid, because if they did leak out, we would have edema. So in order to provide more blood, okay, and more white blood cells and more complement proteins to an injured area, the chemical mediators of inflammation will act on the smooth muscle of arterioles to decrease the total peripheral resistance, basically inducing arteriolodilation. And this will also increase the hydrostatic pressure, which basically will increase the blood flow to the tissue. Again, bringing more white blood cells, complement proteins, and more blood to the injured area. This is the idea. And the chemical mediators which act on the smooth muscle, causing the arterioles to dilate, they are basically histamine, nitric oxide, and prostaglandins. So histamine you know, and prostaglandins you know, and nitric oxide is basically another mediator that it is released due to injury to the vascular connective tissue. So those mediators, they induce arteriolodilation, and all those mediators, of course, they reduce TPR and they increase hydrostatic pressure. So let me just help you understand this concept a little bit better. Okay, so first of all, about the hydrostatic pressure. Normally in our blood circulation, let's say this is capillary. Okay, this is capillary. And this is cells of a certain tissue. Normally, two forces work in this area in order to, let's say, control the exchange of nutrients and O2 and CO2. You know, from the blood to the cells there is a normal exchange of O2. Usually the cells of a certain tissue which want to throw the waste out, for example, will throw out CO2, and of course our blood needs to oxygenate those tissues in order to prevent them from dying, so it will give them O2. So this occurs in the capillaries, which are the smallest blood vessels. And besides CO2 and O2, other nutrients will be supplied to the tissues, and other things will be given back to the blood. For example, CO2 that is given back will go to the lungs, and there it will diffuse to the alveoli in the gas exchange area, and it will get out of our body. So in this area, hydrostatic pressure Basically, it controls, or should I say, it forces the plasma and the blood to diffuse to the tissue. Okay, it forces things in, but of course, if this pressure, hydrostatic pressure increases, then more plasma proteins, more will enter, okay, through the capillaries into the interstitial area and into the cells. So this is one of the forces. Another force which controls this exchange is oncotic pressure, or another name for it is osmotic pressure. So oncotic pressure is another force, and this basically is a force that draws the plasma proteins and the blood back to the circulation. So normally those forces are in such amount that the sufficient hydrostatic pressure oxygenates the tissue, and sufficient oncotic pressure brings back what needs to be brought back. And this is how it normally works. And of course, the interstitial area also has hydrostatic and oncotic pressure of its own, and normally they are balanced. So in inflammation, because, okay, let's say this is arterioles, because histamine, prostaglandins, and NO, nitric oxide, they are released. They are mediators of inflammation. We have it will result in arteriolodilation. So more blood will come, and the idea is that hydrostatic pressure increases, and this is again in order to help bring more blood, more white blood cells, more complementary proteins to this area, so more things will diffuse. And the chemical mediators will also cause production of intraendothelial gaps. Like I told you, in the capillaries we have tight gaps, so nothing can pass, no plasma protein can pass. So basically those chemical mediators will work on the intraendothelial gaps, and those will allow the plasma proteins to leak out of the capillaries, therefore decreasing the osmotic pressure within the capillaries. And the chemical mediators which act on endothelial cells and produce the endothelial gaps, they are basically leukotrienes, histamine, bradykinin, and prostaglandins. So let's draw it out. Okay, if this is intraendothelial cells, normally they are tight, but let's say this is inflammation. So you see this is endothelial cell, and you see there are gap between them, which normally they are not present. They would be tight like this. So in here it's normal, in here there's gaps. So those gaps, they are created by histamine. You remember the preformed mediator inside a mast cell, which releases instantly during inflammation and causes an instant reaction. We also have bradykinin, and you should remember these mediators, they are pretty important. So we have bradykinin, another chemical mediator which increases the intraendothelial gaps, and we have prostaglandins, and we have leukotrienes, which are released a little bit later on, and basically they increase the intraendothelial gaps even further. So yeah. And the increase in hydrostatic pressure and decrease in osmotic pressure will cause the fluid to leak out to the capillaries, to interstitial fluid in excessive amounts without going back due to the low osmotic pressure. Basically an increased permeability of microcirculation, leading to formation of exudate protein-rich fluid, which is. So let me help you understand the idea of the hydrostatic pressure and the osmotic pressure and the leaking out of the fluid through a small diagram. So let's say this is an arteriole, and after the arteriole we have a capillary, which is of course smaller, but for the sake of the diagram we will make it a little bit bigger. Okay, and this is a venule. Okay, this is part of the venular system. So again, the chemical mediators will act on the arterioles, okay, and it will induce arteriolodilation. So if they are like this, they will dilate, and this will increase the hydrostatic pressure. More blood will come in a greater force, so hydrostatic pressure increases. And like I said, the endothelial cells, they are lined with the capillaries are lined with endothelial cells. So the endothelial cells that line the capillaries, usually they are without gaps, but because of the action of the chemical mediators, gaps will appear. And so now fluid, okay, rich with plasma proteins, which are normally they are unable to leak out to the interstitium. Now they will able to leak out, so they will leak out. Now this will be a good time to mention that the osmotic oncotic pressure force is controlled by the plasma proteins. So if plasma proteins leak out, of course the osmotic pressure or osmotic oncotic pressure will reduce. So what does it mean? It means that the hydrostatic pressure increasing is pushing more and more plasma proteins to the interstitium, and osmotic oncotic pressure decreasing is forcing less plasma proteins back from the interstitium inside the circulation. And so inside the interstitium, okay, in the area of inflammation, there will be an accumulation of something that is called exudate. An exudate will accumulate, and it will accumulate as a result of increase of hydrostatic pressure and decrease of oncotic osmotic pressure. An exudate, in simple words, is basically plasma protein rich fluid which is leaking out from the capillaries to the interstitium in order to bring more white blood cells, complementary proteins to the site of inflammation, and blood, of course. So yeah, and another basic concept which we have to understand is, for example, if we do an IV to a person and we put a very tight band-aid, like very tight something that will tie his arm in order for us to do the IV to this person, it will also increase the hydrostatic pressure, but this time the capillaries, because there is no inflammation, there won't be any gap, so plasma proteins won't leak out, but simple plasma fluid without proteins, it will leak out. So now we will have leaking out from the vascular area to a vascular area fluid poor in proteins. So this is called transudate, okay, and it can be seen, for example, again in IV, intravenous injections, transudate, when we put a tight band-aid on the arm, okay, before we do the injection. So this is transudate, this is exudate. Exudate is something that occurs during inflammation. So again, increasing hydrostatic pressure and decreasing osmotic pressure will cause the fluid to leak out of the capillaries to interstitial fluid in excessive amounts, resulting in exudate, because it leaks out without the ability to come back. And again, because it's very important, you have to remember the chemical mediators which induce the arterial dilation. There are histamine, nitric oxide, and prostaglandins, and histamine is preformed in mast cells, and nitric oxide and prostaglandins, they are synthesized later on. And we also have chemical mediators which help us form intraendothelial gaps during inflammation. Those are leukotrienes, histamine, bradykinin, and prostaglandin. And leukotriene is also a mediator that is synthesized later on. So let's do a summary of the chemical mediators produced in inflammation. We have histamine, which is again preformed in the mast cells and released during inflammation, because of mast cell irritation. We have bradykinin and leukotrienes, which is produced by injured cell membranes and activation of certain enzymes that break down the lipids of the cell membrane to prostaglandin and leukotrienes. And this is, again, as I mentioned to you, I'll explain it to you another time. Sorry, I'll explain it to you again because it's pretty important. So, if this is a mast cell and this is the mast cell membrane, due to an irritation, the irritation of the mast cell membrane, phospholipase, okay? Phospholipase. Let's call it like this, PL. Phospholipase A2 will be irritated. The enzyme, it will work and it will break down to arachidonic acid, which will go to two pathways. Do you remember the pathways? Of course, they are cyclooxygenase and lipoxygenase. And cyclooxygenase and lipoxygenase, cyclooxygenase, is responsible for making prostaglandins, like prostaglandin, for example, E2, which is mainly responsible for pain, but also prostaglandin D2 and F2. And lipoxygenase pathway is mainly responsible for making leukotrienes, leukotriene B4, C4, D4, for example. Okay, so this is a quick recap. So all those chemical mediators, they're rapidly formed, and histamine being the very first one released because it's pre-formed. It's the first mediator that is released, and then only then bradykinin and leukotriene. But all of them, they are released relatively quick. So they are released quickly and produce endothelial cell contraction, and of course causing intraendothelial gaps to appear. And later on, also interleukin 1 and 2 necrotic factor will participate. They are cytokines, which they are also, you can say, they are also chemical mediators, and they contribute to the formation of the intraendothelial gaps. So later on, cytokines will be formed and released, and as opposed to those mediators, it takes time for them to be released because it requires transcription of RNA, and then the translation of RNA into certain proteins. So after some time, cytokines will be released, and the immediate increase in permeability of microcirculation again is due to histamine, bradykinin, and leukotrienes. And this type of reaction is called immediate transient response, and it is usually an immediate response. Sorry, there are some misspelling in the slide, but it's called an immediate transient response, which is caused by histamine, bradykinin, and leukotrienes, and usually it is immediate. It occurs immediately. And the increase in permeability of microcirculation is greater on the venule side than the arterial side, since they express more receptors from the chemical mediators of inflammation. Let me explain you this idea. So if we have a capillary, okay, this is the side of the arteriole and this is the side of the venule. So the idea is that the increased permeability, the increased intraendothelial gaps, and the leaking out will be more to this side, to the side of the venule, and this is because those intraendothelial cells, they have more receptors for those mediators than those ones. So this area is full of receptors and this area is kind of poor. So the intraendothelial gaps, this is like a type of question that can appear on exams such as USMLE. So the increase in the intraendothelial gaps is bigger on the venule side, okay, of the capillary than on the arteriole side. And the increase in the intraendothelial gaps again can be due to contraction and retraction, and contraction is a result of histamine, bradykinin, and leukotrienes acting on the endothelial cells of the capillaries, again more on the venule side, and later on retraction because they are required making of mRNA and its translation into proteins. So this is a delayed and prolonged response. So I should explain to you contraction and retraction. If this is an endothelial cells and it contracts, it will become like this. It's contracted, and retraction means that it's not contracted, but it's more like this. It retracts the ends of the endothelial cells. So this is just types of forming intraendothelial gaps. It's not a big deal. You don't have to understand it fully, but this is just two ways of forming the intraendothelial gaps. Again, retraction is done by cytokines, and this is delayed and prolonged response, and the contraction is histamine, bradykinin, and leukotrienes, and its immediate response. Now I would like to mention again some basic concepts related with inflammation about the immediate transient response. The immediate transient response can be a little bit dangerous. This is due to the intraendothelial gaps and the formation of exudate. Why is that? If, for example, there's a large area which is inflamed, for example, burn patient, okay, a patient that has burns over his body, he will have very severe arteriolodilation and very severe and intraendothelial gaps formation due to a very severe immediate response, inflammatory response. So this patient, he will have a lot, and I mean a lot of exudate in, let's say, a very severe case of burn. Okay, in case of a severe burn. So due to the large formation of exudate because of plasma proteins and blood switching site from vascular area to vascular area, the volume inside the blood circulation will reduce. So this patient, in case of severe inflammation, okay, let's say generalized inflammation, he will have a condition of hypovolumia. Hypovolumia. This is basically, you can say it's a shock. And the patient is in shock due to very increased vascular permeability and severe arterial dilation. The patient will be in shock, and of course, because he is in shock, the blood pressure will decrease severely because less blood will be returned to the left heart. This will reduce the systolic blood pressure. So this is one of the concepts I wanted to mention. Now for another concept, the process in which there's the process of in which plasma proteins they switch site from vascular site to avascular site, it's not only through the intraendothelial gaps, it's also through a process called transcytosis. So for example, if this is an endothelial cell, okay, due to action of histamine and other mediators like again the histamine, and let's say also vascular endothelial growth factor, and this is a chemical released by vascular tissue. Due to injury, there will be formation of small vesicles, okay, inside the endothelial cell, and those vesicles, through a process of transcytosis, they will switch side to a vascular area, to the interstitium, from the vascular side. So this is a process of transcytosis, okay. And finally, another quick concept: due to an injury to a certain tissue, we have another process going on, a process of neovascularization. Let's do it in red. Neovascularization due to an injury, because the tissue will have more blood supply, and also in order to help it healing, to help the tissue to heal, there will be a process of neovascularization, which basically means formation of new blood vessels. And this is mainly to help the tissue in healing. So new blood vessels, collateral circulation will be formed. Okay, they are small blood vessels, and this condition is a little bit dangerous, for example in diabetic patients, because if they have, for example, inflammation of let's say the retina, it may cause leaking of exudate, okay, because of intraendothelial gaps, formation of edema. It may result in hemorrhage in the retina, which is a pretty dangerous condition, and in diabetic patients it's something that is certainly possible. So this process of neovascularization, which is intended for healing, and it indeed helps in healing. It indeed helps in healing by supplying more blood supply, giving the tissue more blood supply. Some pathologies may occur due to it. So now that we finished the vascular events, let's go onward to the white blood cells events. So normally white blood cell pass through microcirculation from arterial side to venous side, and of course this is due to normally we do not have intraendothelial gaps, but due to the chemical mediators acting on endothelial cells causing contraction and retraction, in case of inflammation, they will travel to the site of inflammation through the intraendothelial gaps and phagocytose the bacteria or foreign body or whatever is causing the injury and the inflammation. So basic concept again to understand is that normal blood flow is a linear or laminar pattern, and this is basically a very basic thing to understand, is that the blood flows like this, that the molecules inside the blood, they are arranged during the flow according to their molecular weight. So they pass through circulation in a certain order. For example, largest molecules will be at the center and smallest will be at the periphery. So therefore, normally the white blood cells will be on the center because they are larger. So they will be in the center of the blood flow, while on the periphery we will have red blood cells and platelets, and on most of the peripheral part we will just have plasma. So again, it's very basic. I don't think that you even need a concept, but let's make a concept anyways. So a normal blood flow is laminar. In the center we have larger molecules like white blood cells. Okay, their weight is pretty big. Okay, so if you do electrophoresis, which is a test for a molecular weight, you will see that it's bigger than red blood cells, which will be at the periphery along with platelets. Okay, platelets and RBCs, they will be in here, and on the most peripheral part, which will just plasma. Okay, so this is very basic concept to understand. In inflammation, due to the dilation of the arterioles and the formation of the intraendothelial gaps, which will result in exudate, the remaining cells within the fluid will be the remaining cells and fluid within the circulation will become more concentrated, and therefore they will become more viscous, and it will result in blood moving more slowly with less velocity, and this will result in hemostasis. So what does it mean? Basically, due to the arteriodilation and the formation of the intraendothelial gaps, some fluid passes, okay, to the interstitium from the circulation, and this reduces the plasma proteins inside the circulation. So what remains inside, because more fluid passes and exudate forms in the interstitium, what remains inside, logically it will be more concentrated, and because it's more concentrated, the blood flow is like more congested. It becomes viscous, and the blood flows more slowly. Because the blood flows more and more slowly, it results in hemostasis. Blood stops. Stasis. Blood stasis stops. So it serves, of course, it has a purpose. The purpose is to allow more time for the components of white blood cells to switch side to the vascular tissue and help recover and help to remove what causes the inflammatory process. So besides that, it also has another purpose. Because of the hemostasis and the viscosity of the blood, and because some fluid and plasma proteins leak out, there's a certain change in the way of the luminal blood flow is arranged. So because the red blood cells will be more concentrated, because certain plasma proteins switch side, they will aggregate together, and now because they aggregate together, they're like connected, so their molecular weight will be bigger than the white blood cell. So now they will switch side. Instead of flowing in the periphery, the white blood cells will switch in the center, and the white blood cells, they will be pushed to the periphery. Okay, so we have switch of molecules, and white blood cells will be at the periphery, and this will help them to advance to a closer place where they can pass through the interendothelial gap. So instead of the center, they will be in the periphery. Okay. And during hemostasis, the blood flow can be maintained as linear, again, as I told you, because the red blood cells will clump together, resulting in them being in the center of the flow, and white blood cells will be at the periphery. So you now know this concept. Next thing about the white blood cell events is that the white blood cells will migrate to the periphery, like I told you, because of the change in molecular weight, okay, aggregation of the red blood cells. And because the white blood cells will now be at the periphery, they will stick to the endothelial cells. And this process of the white blood cells that stick to the endothelial cells can be broken down to like a couple of parts. So the first thing is that the endothelial cells will have special granules inside them loaded with p-selectins, okay? And p-selectins, you can also call them sticky molecules, and so those special granules loaded with p-selectins inside them, together this whole thing is called viable viable, I hope that I pronounced this right, but viable palate bodies. So this viable palate bodies complex granules plus p-selectins, it will be released due to the action of histamine, leukotriene 4, it means leukotriene B4, C4 and E4, and thrombin, which are released during inflammation. They will act on the endothelial cells and they will cause the release of p-selectins on the surface of the endothelial cells. So let me draw it to you. If this is an endothelial cell, okay, of a capillary, inside the endothelial cell there are special granules with palate bodies. Why viable palate bodies? This whole thing is viable palate body. When histamine and thrombin and leukotriene will act on it, okay, PG, prostaglandin, leukotriene, and histamine will act on the endothelial cell, the viable palate body will be released and the p-selectin will be released and it will stick on the endothelial cell. So this is basically p-selectin, and you should remember probably that p-selectin is expressed on the endothelial cells through viable palate bodies due to action of prostaglandins, leukotrienes and histamine. Sorry, I want to correct myself. Leukotriene, histamine, and thrombin. Okay, thrombin. They are the ones. They are the mediators that act on it. So switch up prostaglandin with thrombin. Okay. Next thing in this process is that white blood cells contain oligosaccharide extensions which help them to stick to the selectins. So what does it mean? If this is the circulation, and again the white blood cell will be in the periphery. So if this is white blood cells, basically what it means is that they contain oligosaccharide extensions, and those extensions will help them stick to the p-selectins. Okay, oligosaccharide means that it's like it's a carbohydrate, okay, monosaccharide or oligosaccharide, and basically it helps the white blood cells to stick. Next thing is interleukin 1 and tumor necrosis factor. If you remember, we mentioned them previously as cytokines. They are not preformed, they come later on because of it takes time to synthesize RNA, translate it to proteins and so on. So they will stimulate the endothelial cells and they will produce E-selectins, which will make the endothelial cells more sticky. So what does it mean? Tumor necrosis factor and IL-1, am I correct? Yes, tumor necrosis factor and IL-1 will be synthesized later on, and they will cause the expression of E-selectins. So on the endothelial cells we will have E-selectins and P-selectins expressed, and the sole purpose is to help the white blood cells to stick to the endothelial cells. And the final thing about this whole process of stickiness is chemokines like interleukin 8, which is released also by macrophages, will be released and act on white blood cells and cause them to express integrin molecules, which will further help the white blood cell to stick to the endothelial cell. So integrin will bind to, maybe I should draw it to you. Now let's say interleukin 1, another mediator, okay, going to also release by macrophages again. Like I told you, it will act on the white blood cell and help in the expression of integrins. So this is the green ones, they are integrin molecules, and those integrins, like the name suggests, they integrate. So basically, if selectins help the white blood cell to attach, integrins help the white blood cell to integrate. So again, integrins, they are responsible. They are made by the IL-8, interleukin 8, and they will integrate with the endothelial cell through special molecules. Those special molecules, the brown ones, which will have association with the integrins, they are called VCAM. And also ICAM. This is short for vascular cell adhesion molecule and intracellular adhesion molecule. So vascular cell adhesion molecule and intracellular adhesion molecule, they will associate with the integrins and help the white blood cell to integrate. But before that, of course, P-selectin and E-selectin will be expressed on the endothelial cells, and also oligosaccharides will be expressed, and it will help in the attachment. Only after this, IL-8 will cause the expression of integrins, and it will integrate with the help of ICAM and VCAM. So after the white blood cell events and the interaction and integration of white blood cells and endothelial cells, we move onwards to the white blood cell movement from the blood circulation to the interstitial fluid. So after sticking to the endothelial cells, the white blood cells will come from a vascular compartment to a vascular compartment by a process called migration, and migration is a key word, you should remember it. Migration of white blood cells from vascular compartment, okay, the blood circulation, to the interstitial fluid. And basically it will be caused like this. The white blood cell will integrate with the endothelial cell, and after integration all those molecules, integrins and oligosaccharide, they will rub against each other with E-selectins, P-selectins, and VCAM and ICAM. They will all rub against each other. This is called homophilic action. So through an homophilic action and with the help of CD31, okay, CD31 molecule, which will help in the homophilic action, the white blood cell will start slipping to the endothelial gap, and by expressing collagenases, the enzyme that digests collagen, it will form an hole in the basement membrane. Okay, this is the basement membrane on which the endothelial cell sits. It will move from vascular compartment to a vascular compartment. So the white blood cell will appear in here. Okay, so this white blood cell has came right over here, and after coming from a vascular compartment to a vascular compartment or interstitium through the process of migration, through homophilic action, the white blood cell that came out of circulation will pass through interstitial fluid. Of course, after the white blood cell came out of circulation, it will pass through interstitial fluid by digesting the basement membrane to collagenases. And after passing to the interstitial fluid, the white blood cell will go to the site of injury through a process called chemotaxis with the help of chemokines, which are present at the site of injury. So basically, what does it mean? It means that if it's, for example, the site of injury is here, and in here there's a nasty bacteria, okay? This is a nasty bacteria. This is the site of injury. At the site of injury, there are special molecules which are called, and this is important, they are called chemokines. Chemokines. And they are responsible for a process of chemotaxis. Chemokines molecules can be different things. They can be, for example, if there is a mast cell in this area, okay, some part of the chemical mediators of inflammation, like leukotriene. It can be a chemokine or a complement protein. Complement protein is a special plasma protein which helps in the lysis of the bacteria, and those complement proteins, they connect with each other. Okay, they are connected. Let's say this is a complex of complement proteins, and when they connect with each other, they release stuff like, for example, complement protein 5A, which this is like a dissociation molecule that comes from the connection of the different complement proteins together. So C5A acts as a chemokine. Or maybe it can be a bacterial product. A bacterial product released by the bacteria itself, and this will attract the white blood cell to the place of the inflammatory reaction where the bacteria or maybe foreign body is found. So some of the chemokines, chemical mediators which attract the white blood cells, like we already mentioned, some they are bacterial, of a bacterial origin. For example, the bacteria produces a special protein with N-formylmethionine amino acid, and this is basically a type of bacterial toxin which will serve as a chemokine. Some chemokines of chemical mediators which attract the white blood cells are a product of our cells. For example, leukotriene B4, again from the irritation of it released by mast cells, and can also be released due to an injury to a cell membrane of a macrophage. And some of the plasma proteins that leak out are complementary proteins which help in the lysis of the bacteria, and after getting activated, some molecules will dissociate from them, like C5A, and they have a chemotactic effect on the neutrophils. So the main chemokines that you should remember which attract the neutrophils, the white blood cells, during inflammation, they are leukotriene B4 that is released by mast cells and macrophage, and C5A, which is a dissociated molecule from the complement proteins, and bacterial products like a bacterial toxin. So after getting attracted, like sensing the chemokines, the white blood cell will start moving towards the chemotactic agent. For example, it will binding of neutrophils LT leukotriene B4 receptor of a neutrophil to a leukotriene B4 molecule. It will cause the activation of neutrophils motor through a GQ protein coupled reaction. And I will try to explain it to you. It's a fairly basic concept. Okay, so basically, if this is a neutrophil and this is a receptor, let's make it bigger. If this is a neutrophil, this is more like it, and this is a receptor for leukotriene B4, and this is leukotriene B4 molecule released again by mast cells, irritation or by macrophages, and it will stimulate the receptor. So basically what will happen next is that it will basically give the neutrophil a signal to activate molecular motors which will move the neutrophil towards the site of injury. And first thing is that it will stimulate a serpentine receptors. Serpentine receptors, basically, they are receptors that pass through the membrane of the neutrophil or any other cell. Basically, it's just a type of receptor 7 times. So 1, 2, 3, 4, 5, 6, 7. Serpentine receptors are also called 7-pass receptors because they pass to the membrane of the cell they are connected to. They are connected to 7 times. Maybe I will do a future pharmacology lecture about it, so it will help you to understand better. But for now, just trust me about this. So after the serpentine or 7-pass receptor is stimulated by the leukotriene B4 molecule, it will be coupled by a protein which is called GQ protein. GQ protein. There is a coupling of the receptor with this GQ protein, and this coupling will stimulate another. It will stimulate basically an enzyme, and this enzyme is phospholipase C. Yes, phospholipase C. This is the enzyme. So the coupling of 7-pass receptor with GQ protein molecule because of leukotriene before stimulation will stimulate the enzyme phospholipase C2. Sorry, not phospholipase C2, just phospholipase C. And this enzyme's special function is that it digests a part of the lipid membrane of the neutrophil. Basically, it breaks down the lipid membrane of the phospholipids of the membrane of the neutrophil. So the membrane some components of this phospholipid B membrane is a molecule called phosphatidyl inositol diphosphate, or for short PID. So phospholipase C will break down PID, phosphatidyl inositol diphosphate, and PID will be broken down into two molecules, which are diacylglycerol. This is the first one, diacylglycerol. The second one is inositol triphosphate. Inositol triphosphate. So again, let's recap. Stimulation of leukotriene B4 of a serpentine receptor of a neutrophil will couple with GQ protein, which will stimulate phospholipase C, which will break down phosphatidyl inositol diphosphate to diacylglycerol and inositol triphosphate. And now the real action begins. Inositol triphosphate, it will stimulate inositol 3 pumps in endoplasmic reticulum. So for example, this is endoplasmic reticulum. It will stimulate inositol triphosphate pumps, which will then release calcium. Okay, so stimulation of inositol triphosphate in the endoplasmic reticulum will release calcium, and calcium is an ion which will be released in the cytoplasm, and it will bind to a calmodulin molecule. Calmodulin molecule plus calmodulin and besides binding to calmodulin, it will also stimulate the enzyme protein kinase C. Protein kinase C. And the stimulation of protein kinase C will phosphorylate along with calmodulin filaments of actin and myosin. So those two will phosphorylate molecules of actin and myosin filaments, and those filaments of actin and myosin, when phosphorylated, they will activate the motor mechanism of the neutrophils and will cause the movement of the neutrophil towards the site of injury. So again, recap: leukotriene before stimulation of serpentine receptor will couple with GQ protein, will stimulate phospholipase C enzyme, which will break down phosphatidyl inositol diphosphate, part of the membrane of the neutrophil, which will be broken down to diacylglycerol and inositol triphosphate. Inositol triphosphate will go to the endoplasmic reticulum and will cause the release of calcium. Calcium will bind with calmodulin and will stimulate protein kinase C. Both will phosphorylate actin and myosin, which will cause the movement of the neutrophil towards the site of injury. So this is the basic motor principle of the neutrophil, which will help during inflammation. Before we finish, I want to associate or like clinical correlate some conditions with inflammation. So first one is LAD2, which is leukocyte adhesion deficiency. In this condition, the white blood cells are missing the oligosaccharide extension. If you remember correctly, those the extension oligosaccharide extensions which are connected to white blood cells, and they help in the interaction of p-selectins and e-selectins, and basically in the this is basically an interference with the integration of the white blood cells with the endothelial cells. So in this condition, the result will be less white blood cells coming to the site of inflammation, because there is no interaction between the p-selectin and e-selectin and oligosaccharide extensions which are missing due to the LAD2. And this condition occurs due to the genes which are responsible for making those oligosaccharides not being functional. So this is one condition. Second condition is neutrophilic leukocytosis. This is basically high level of neutrophils in blood circulation. People with high levels of catecholamines, corticosteroids, or patients who take lithium, which is a drug used for bipolar disorders, they will have elevated levels of neutrophils in the blood, called neutrophilic leukocytosis. It occurs because of high level of catecholamines, corticosteroids, or lithium, which prevent the endothelial cells from expressing adhesion molecules like p-selectin and e-selectin, preventing neutrophils from sticking. In this condition, basically less neutrophils will come to the avascular compartment or to the interstitium, because the endothelial cells themselves, they will not have p-selectins and e-selectins, which will help in the integration of the white blood cells with the interaction of oligosaccharides extension with there won't be interaction of the oligosaccharide extension with the p-selectin and e-selectin, so it will result in more neutrophils staying in the circulation, and this condition is called neutrophilic leukocytosis. The final condition is neutropenia. This is low neutrophils blood levels, and it can be caused due to endotoxins released from gram-negative bacteria. They help endothelial cells express adhesion molecules, causing a lot of neutrophils to stick to endothelium and migrate. And a condition like endotoxemia will result in neutropenia. So basically, this is like a more elaborate process of migration due to overexpressed adhesion molecules on the endothelial cells. So adhesion molecules, it means e-selectins, p-selectins, and maybe ICAM and VCAM. If you remember correctly, VCAM is vascular cell adhesion molecule, and ICAM is intracellular adhesion molecule, and basically it will help more neutrophils to migrate, resulting in neutropenia, decreased white blood cells, or decreased neutrophil count in the blood, result of endotoxemia. Thank you for listening to the lecture about inflammation. If you have any comments, please leave them below. If you are interested in hearing, if you are interested in me doing a lecture about a certain topic, also please leave a comment below, and of course like the video. Thank you.